Hello, and welcome to a session on qualifications for long-term care pharmacies. We want to make sure that as a long-term care pharmacy joining GeriMed, whether you're a closed-door pharmacy or a combo pharmacy that services both retail and long-term care, that you are doing and have the capacity to do all of the qualifications required by CMS to be in the program. My name is Susan Rodas. I am a pharmacist by trade. I'm a Senior Vice President of Contracts and Advocacy for GeriMed. I've been with GeriMed for 35 years and worked in long-term care for more than that. I always joke around and say I started when I was 10. First slide we're going to go over is what qualifies you as a long-term care pharmacy. Who do you have to be servicing? Which types of patients do you have to take care of in order to be qualified to be in this program? So here's a list for licensed facilities that you could take care of. So we're going to talk about nursing homes and long-term care rehabilitation facilities, which is federally regulated. Those have rules they have to follow both on the federal level and the state level, which is really challenging for those facilities to be able to follow all of those rules. Assisted living, sometimes called personal care, sometimes called group homes. They're all licensed by the state. So they still have to have a license. They still have to have certain qualifications in order to be considered an assisted living, personal care, or a group home in that state. And that is a requirement that they have to fulfill. Next, you have ICF IID, used to be called ICF MR for mentally retarded. Now those facilities have their name changed. So IID stands for individuals with intellectual disabilities. They have to follow rules that apply federally, and they also have state rules as well. And the rules that they have to follow, including things like having a consultant pharmacist, having a pharmacist that comes into the facility on a regular basis and make sure that all of their medications are stored appropriately, etc., apply both to the nursing homes and the ICF IID facilities. Then you have group homes for intellectually developmentally disabled people. That is run by the state. Again, those facilities will have some type of license that they have to follow. They can't take and put 5 people in a home and say this is a group home. They have to have license and standards that they have to follow. Hospice can be in a facility. A lot of times the hospice patients in assisted living or any nursing home. They also have standalone hospice facilities, but a lot of hospice patients are taken care of at home. And so you see them in a variety of different places where hospice services are rendered. Jails and prisons, those are state and federal. Those are always paid with a per diem. They are not paid by having someone run a claim through Medicaid or run a claim through a PBM. They are done as a per diem. The only exception to that would be someone who's incarcerated, but they haven't gone through trial. They may have something that they have to take care of with running something through a commercial claim or other claim because they're really not in the jail or prison long term. Drug and alcohol inpatient facilities, they should be, again, put in by the state as far as what they have to do as far as what they have to accomplish with those type of facilities. Usually they're in there. A drug and alcohol inpatient rehabilitation facility is usually for 30 days. It's not somebody's in there for 2 or 3 days and then they leave. Behavioral health or outpatient mental health centers, that's more for people who are administering LAIs, so long-acting injectable antipsychotics, or other agents that they may be receiving at the facility. And they can come and go for that, and you have to be careful about billing for those patients. You are able to use GeriMed contracts for them, but you may have to bill those patients through your retail side. And then last, you have chronic psychiatric facilities. It's inpatient. Again, that would be for someone staying there for usually 30 to 90 days. It's not somebody who's going to be in there for a short period of time. And you say, well, what about long-term care pharmacy at home? Long-term care pharmacy at home is relatively new. It is a term that has come out because a lot of people want to stay in their home. We have can get more information to you if you're interested in this practice and you're not currently doing it. The patient must have difficulty leaving home on their own, no driving. I've had questions from people who said, well, Mrs. Jones only drives on every Monday, so she's an occasional driver. Does she qualify? No, if she can drive on Monday to your pharmacy to pick up a prescription, she does not qualify. She's retail. The patient must have 3 or more chronic conditions. They must be getting multiple maintenance medications, and by multiple, our definition is 3 or more medications that they receive on a regular basis. They must need assistance with 2 or more ADLs or IADLs. If you need explanations of those, we can get you more information about that if you contact us with questions at the end. There's an email address that you can send questions to. We'd be more than happy to assist you with that and get you a list of what those ADLs and IADLs are. They can participate in a Medicaid home and community-based waiver program, which should automatically qualify someone for this program because the government has already assessed them as being at the same level as a skilled care patient. And then last, you have a PACE program. A lot of the PACE programs will qualify people. That's another way to determine whether or not they have the qualifications that they need. More information can be found on pharmacyathome.org, which is the Alliance for Long-Term Care Pharmacy at Home. Talks a lot about the patients in there. It talks about the qualifications that you need to do specifically for long-term care pharmacy at home as a long-term care pharmacy. And it will have more information here coming soon. This is done in August. We hope by September to have an attestation statement that can be used for everyone. We're trying to make a statement that is across the board for everyone that you can use for that. So let's talk about the CMS requirements for network long-term care pharmacies. They were instituted in 2006 as part of the Medicare Part D criteria for insurance sponsors to provide access to residents of nursing homes for Part D prescriptions. CMS has recognized that long-term care residents required more services than community Medicare Part D beneficiaries. And you say, well, wait a minute, this is talking about nursing homes. Well, CMS has come out with other letters going forward that talk about assisted living and other congregate living systems, which would be group homes and all the stuff we just talked about. So they have come up with memos regarding that. Their last memo that was done in December of 21 talked about patients needing care in their home. So long-term care pharmacy at home. The big deal is that they said that you could do this. It didn't say that you had to do it. So the PBMs are not paying extra money across the board for long-term care pharmacy at home. Notice, and I'm going to read this statement because I think it's really important. To qualify as a long-term care pharmacy for a Part D sponsor's long-term care pharmacy network, a pharmacy must currently have the capacity, either by itself or through subcontracts with other entities, to meet all of these performance and service criteria, even if a long-term care facility that pharmacy serves does not need a particular service subsumed under those performance and service criteria. So you have to be able to do things, and we're going to talk about IVs. You have to be able to do IVs. You may never have to do an IV, but you have to have the capacity to do an IV. And so that's very important that you make sure that you are able to do everything, including things like an emergency kit, which we'll talk about later. Emergency kits primarily across the country are only required in skilled nursing facilities and nursing homes. They're not required in assisted living facilities, but you still have to have the ability to do that. If you walked into a skilled facility and started taking care of them in the next month, you would have to have the capability of doing that. And a lot of the PBMs are starting to audit on that. So I will definitely talk about that more in a later slide. CMS performance, here are the criteria, and we're going to go through all of these. These are the 10 criteria that CMS put in place back in 2006 with the start of Medicare Part D. Comprehensive inventory and inventory capacity. Medications not normally stocked in a retail pharmacy, liquid formulations, IV medications, all of those type of things must be able to be in stock. And whether you're a closed-door pharmacy or you're a combo med pharmacy, you need to have the ability to stock medications you normally would not carry for your retail population. And so that's very important. I think the IV medications, even in something like a group home, sometimes they require IV medications for seizure prevention or things like that. So it's important to have that ability to have those available. You must have adequate stock to fulfill those orders and prescriptions daily. And that means that you've got to be able to have that stock sitting there. You can't wait 24, 48 hours to get a delivery out for a medication. Urgent orders are considered to be 4 hours. New maintenance orders would be within 24 hours. So you can't sit there and go, well, I got to wait 3 days to get it from some, obscure specialty distributor that is 3 states away. You need to make sure that you have access to the drugs that you need to have to take care of these patients. OTC medications should be available as well. Some can be floor stock in some states, while some should be individually done. Prescriptions or chart orders must be written for OTCs and prescription medications. That is very true in skilled facilities. You've got to have an order for that prescription. In a facility like an assisted living or a group home, you should have it in there, because otherwise, if you translate everything over to a electronic health record and they have a medication administration record within that health record, you need to be able to have that information in their EHR record. Pharmacy operations and prescriptions orders. So you must meet the requirements of pharmacy practice for dispensing prescription drugs to long-term care residents, including but not limited to the performance of drug utilization review. You must have pharmacy software to accept and process both electronic and written prescriptions. And in skilled facilities, you have to be able to perform the tasks in the facility and follow the state operations manual appendix PP. Here's one of the latest ones out there you can read. Section 483.45 is what you need to follow. That document is over 1,000 pages. So I'm not expecting people to read 1,000 pages, but you should read that section that's on pharmacy if you intend to do anything with skilled facilities or ICF IID facilities. You also need to have a policy and procedure for both the pharmacy and each facility. So the nursing home, assisted living, group homes available for review with the PBMs. So if you don't have a policy and procedure manual that's separate from your retail, if you're a combo pharmacy, you have a problem. You need to get one. You need to set that up. You need to have it specific to your pharmacy. Okay, not a template agreement or a template booklet that you got from somebody that you knew down the street that has all of their information in it. You need to have it specific to what you are doing. It should be done that way, not based on what somebody else does in their pharmacy. It should be how your procedures and policies are written up. Policy and procedure must include when orders are sent to the pharmacy, when they're delivered, how controlled medications are ordered and delivered. Some associations have sample policy and procedure manuals that you can look at. Make sure that you're following what they needs to happen. Rules for assisted living and group homes you can get on this website that has all that information state by state on what you have to do and not do, and what the facility is required to do and not do. So it's important that you make sure that you are having information on the other side for that facility on how to get a hold of you, when they should expect your orders, what they need to do if they lose a order or need something to be reordered. Those are all the kinds of things that they need to have in their policy and procedure. And you say, well, I'm doing long-term care pharmacy at home. What do I need to do that for? Well, in long-term care pharmacy at home, you should have some type of information sheet for the caregiver or the patient on how to get a hold of you, how to get a hold of you after hours, or if you have a service that you want them to call, how to store medications, especially if you're talking about liquids or refrigerated products. You should have all of that information on a sheet or multiple sheets for the patient to have at their home. You're taking care of them as a long-term care patient, so you need to treat them that way. Special packaging. Special packaging is required. No vials for anything that is in a oral solid medication. So capsules and tablets must be packaged in special packaging. Doesn't matter if it's a PRN, an as-needed medication, or it's a maintenance medication, should be packaged in the special packaging. And there is no such thing as capacity to do this and that you can dispense in vials. No, the capacity is that you're the one doing it or you get someone else to do it. It has nothing to do on whether it's required or not. Special packaging is a mandatory piece of this business, period. It must be provided in 30 days or less. You can do 31 days if you're doing a nursing home, but a lot of times the plans are not recognizing 31 days in assisted living or group homes. And so you're going to be in trouble if you submit a 31-day supply. You're going to end up with 2 copays for the patient. And I doubt it if any of those patients want to get 2 copays. For brand oral solids, you must have fill with 14 days or less. That must be provided for brand oral solids in nursing homes. Assisted living, group homes, and ICF IID are exempt from this requirement. So the 14 days or less follows that rule. If you look in our weekly dose that we have out, there's literally a list published every quarter that has a list of all of those products. It's important to note that on the short cycle fill, it's not just branded products 100%. If there's an authorized generic that comes from a company like Pfizer has Greenstone, all the Greenstone products are literally from Pfizer. And so those products must also be packaged in 14 days or less and are technically considered brands. So make sure that you review that list on a regular basis. Like I said, it's updated every quarter and it is in the weekly dose. If you're not getting the weekly dose, I highly recommend you get in touch with your sales representative at GeriMed and make sure you're receiving that information. Oral solids, with the exception of products that must be dispensed in oral containers, must be dispensed in compliance packaging. So you talk about a drug like Linzess. Linzess has on the bottle itself to dispense an original container, then you need to dispense it in the original container in order for you not to be subject to an audit. We have seen these audits a lot for these products that are supposed to be packaged in the original container because of issues with storage, etc. If you have questions about what should be packaged and not, please feel free to reach out to us. Options include punch or bingo cards, disfill cards where you have multiple medication in each bottle, bubble, pouch or pillow packages with one or more multiple medications in each package. You can do whatever ones of those that you want, but it's got to be special packaging. Patients with unstable chronic conditions may need to have their medication dispensed for less than 30 days to avoid delivery of separate packaging for new orders and repackaging of other medications. Other products like insulin, creams, ointments, and ophthalmic products may need to be dispensed in more than a 30-day supply. So insulin, I highly recommend using pens. Pens can be, in these situations, have the box open. If you need to know more about that and how to do it, we have an article that's been set up. Again, contact your sales representative and they'll be more than happy to provide that letter for you that explains how to do it. I highly recommend that insulin are done in pens. It's much easier for the caregiver or the nurse or whoever to administer it and make sure they do it correctly. Just keep in mind that other products can be dispensed in more than 30 days because if that's how they're packaged, that's how they have to be delivered. Packaging is very important for adherence. You can see on here all the different types of packaging. It's important that that is the packaging that you're doing. It's something that you need to keep in mind when you're working through this. And you can have more than one packaging system at your pharmacy. That's up to you what you do. I highly recommend if you're doing business with facilities, one of the tactics that's used by some of the bigger players is they say, okay, this is the only package you can have, and maybe the nurse doesn't want that. IV medications. This is another one that a lot of people have a lot of questions about. This is one that you have to have the capacity to provide the IV medications regardless of setting. So again, it's not the capacity to do it and you don't have to do it. It's the capacity that you can provide it if someone needs an IV medication. So there need to be sent out. You can do it yourself. If you have a clean room with a hood, you can go ahead and do that. You need to use ready-to-use products if you want to. That would be another way to be able to have this available. If you have products like Advantage, where you literally push through on a drug to get that product put into a piggyback, or you can subcontract with a hospital, home infusion, company or a company that provides after-hours services, GeriMed has a contract with Care Services. That's one of the services they provide. You can talk to them about getting set up in order to provide IV medications to your pharmacies. Compounding or alternative forms of drug composition. Most compounds used in long-term care are not sterile and are fairly easy to make, like combining two creams together. If you feel comfortable doing that, and you don't need to have anybody doing complex compounds, you don't have to worry about that, and you can just go and do that. But if you think you're going to have complex compounds and you don't feel comfortable making them, you can again subcontract it with a pharmacy specializing in compounding or sterile compounds if they are required. Again, the pharmacy must have the capacity to provide the ordered compounds. So if you get an order for something and you can't make it, you need to find someone who can assist you with that and have a contract with that particular provider to provide that particular medication. Pharmacist on call. It doesn't matter if you're a long-term care pharmacy at home, your assisted living, your nursing home, you've got to have a service to answer the phone. This is one thing that several of the PBMs have audited on, where they will call the phone. And if you don't have a way to get a hold of them after hours, that's considered a problem with that particular PBM. So make sure that you have that capacity to take that. You can have pharmacists take call and rotate with your pharmacists and put them on call in different hours. If I was a pharmacist taking call, I would want to be paid for that time, because you're always on call and you always have an issue where you have to answer the phone. Even if they just answer the phone and have delivery with a separate pharmacy to do that, that would be fine. You can do that as well. We do have, again, a Care Services contract that are available to take calls and set up delivery of emergency medication with 24-hour pharmacies in your area. You now know that there's a lot less pharmacies out there that do 24-hour services. So that, again, may be something that you're interested in doing. I highly recommend, if you don't have this service set up with somebody, that you do that, or you know that you're going to take that on yourself. Again, you have to have answering questions, delivery of emergency medications for all patients, including long-term care pharmacy and home. My guess is most of the time you're going to get questions, and you should be able to take questions 24/7. But sometimes you may have to deliver a medication like an antibiotic in the middle of the night. If these patients are very sick, they may require that you do that. Delivery service. You must have at least daily delivery available to all facilities. Nursing homes, if you're taking care of those, most require 2 delivery services a day, like a stat in the AM and an early afternoon, a regular delivery in the late afternoon or early evening. Some nursing homes have a lot of patients being admitted later in the evening, and it can become a problem. So I highly recommend that you work with the nursing home to make sure that they do it in a proper manner. Most long-term care pharmacy and home patients should have at least 1 delivery per month, plus any delivery for changes in medications. Deliveries must have a manifest signed off by the personnel at the facility, either electronically or on paper. I'm going to go back to that for a minute. I just want to talk about, some people are, for long-term care pharmacy and home, are having a case where a caregiver wants to pick the medications up. That's okay, but you need to have a waiver saying that they agreed to do that, and that should be stored in their file. That is not a regular service, and it should not be done with the majority of your patients. It should be a one-off because somebody has decided that they want to do that. Please do not do that on a regular basis. That should not happen. You should be delivering these medications to the patients themselves. That's the whole idea behind this service. And then miscellaneous reports, forms, and prescription ordering supplies. Most of these reports are electronic, but some assisted living and group homes may still have paper medication administration records. Pharmacy and the facility should match as far as what's dispensed by the pharmacy and what's on the medication administration record. The best way to do that is to have an interface with your pharmacy software to whatever electronic healthcare records that they're using at the facility. And you should be either checking that, or you should be approving it before it gets put into the medication administration record. There's a lot of different services, a lot of different ways to do this. Make sure you take a look at that. Many facilities order by sending in copies of labels for reorders and send it back. And controlled medications need to be counted and accounted for on a shift-by-shift basis. So forms may be needed to be provided at the facility as well, so that they can count medications that are controlled. Emergency boxes and logs, they're required in nursing home. That's a federal requirement. What can be put in those is determined by the state. So you need to go check either your public health rules or your nursing home rules to see how they do that. Some of them have the medical director, the DON, and the pharmacy make a decision on what goes in that box. Some of them say the medical director does it. Some of them say this is a list of drugs you can put in here. You need to make sure that you have a list of those. You do not need an emergency box or logs for LTC pharmacy at home to put in their literally in their home themselves, but you need to have that capacity to do an emergency box. So we highly recommend that you go to a big box hardware store or to your local, tackle box place where you have fishing supplies and buy a tackle box or a box for tools. And you set that up in your pharmacy with some plastic locks. You can buy those from Amazon, or you can get those plastic locks from RD Plastics that we have on contract, and have those set up and ready to go, that for whatever reason you needed one of those, you could have that and be ready with taking care of that. You can use the least expensive choice, a tackle box or a toolbox, and they literally have boxes called Cubexes and other brands of that, where the nurse is the only one allowed to do that after the pharmacy authorizes a medication. So you can do it as crazy as you want to out there. You can have a variety of different ways of setting this up. Again, because PBMs are auditing people, I highly recommend you go buy a box. It'll probably cost you, 20 to 50 bucks to buy a box, and get those little tabs, probably cost you 10 bucks. Put a label on it, call it emergency kit, and let it sit there. If you need it, you got it. Other services that you can have out there are consultant pharmacist services. You can do that yourself with your own pharmacist, or you can farm that out and hire somebody to do that at a facility. Most of the time, you're talking about assisted living and nursing homes. Nursing homes, it's required monthly. Assisted living depends on the state. Some of them do not require it. Some of them require it quarterly. There's a few that require it monthly. Check in your state regulations. Coordination of care is an extremely important piece for long-term care pharmacy at home and for assisted living. You want to speak to the prescribers and the caregivers or the patient to make sure that everything is set up every month for that patient. Those calls should be made monthly. You're getting paid extra money, and the whole idea is getting paid extra money for doing these services by doing extra things. And so that's another piece of the pie that you should be setting up and doing on a monthly basis. Thinking of medications, cycle fills for facilities, that's a good way of getting that set up and not having to rely on a nurse to reorder medications. They're going to have that. Just be careful, because sometimes it gets really crazy, and you have people who have literally closets full of medications that they can never use because people kept sending them medications. So always go out to the facility. I would say send a technician or a pharmacist out to a facility that you're doing all the business in, I would say at least every quarter, to make sure that they don't have a stock up of supplies that they don't need. They're not sending you back expired medications, etc. And then reconciliation is always important, especially for patients who are returning from a hospital or a nursing home. Maybe they were in a nursing home, now they're at home. Make sure that you always reconcile their medications, because as you know, the hospitals change all the medications all the time. And when they come back, they're on completely different medications than what they were on when they were with you before. Or even as a new patient, they may be on completely different ones than they were in retail. So long-term care pharmacy is helping vulnerable patients. And so more and more people, we're going to have the most people over the age of 80 in the year 2040. That's 15 years from now. It really is important to make sure that these patients are taken care of. And, again, pharmacy school, if you guys are pharmacists, pharmacy services, including prescribing the right drug, taking the right drug, right time, right dose, right route, is super important. Coordinating care to make sure a patient doesn't have duplicate drugs, needs new medications. That's a super important piece. And technically, you as a pharmacy are probably the one provider who can coordinate all this. One doctor's not going to do this, because if they see 5 doctors, they really aren't going to have that coordination of care. If you have any questions after you viewed this webinar, please feel free to direct them to my email address, which is written on here, srodas@gerimedgso.com. Or you can contact your network coordinator, or you can contact your sales representative if you have any questions about any of these pieces that I've described. Thank you for listening today. We appreciate you. And again, please know that taking care of patients who are vulnerable is an extremely important piece of our business and our world. And we need to make sure that we do our jobs in taking care of these patients who really need us. And it really can make your pharmacy thrive if you do it right. There's a lot of information out there from NCPA and ASCP that you can use to really make this a good place for you to be at. Thank you very much. GeriMed appreciate you.